interventions in ear and hearing care. We are going to have a beautiful discussion. I'll go ahead and give and introduce our speakers. Our speakers today, we have Sarah Ndegwa, who is a consultant audiologist in University of Nairobi. Our other speaker is Mr. Manasseh Bocha, who is the Chief Clinical Officer in the Ministry of Health and our point in ear and hearing care. Then we have the Assistant Professor Ziva Genasan, MASLP, who is in a Madras ENT Research Foundation and Institute of Speech and Hearing in Chennai, India. We'll also be joined with Dr. Ngugi, who is a head and neck surgeon, in the discussion. So I'll invite each of them to say hi. Let's start with Sarah Ndegwa. Ms. Sarah Ndegwa, welcome.
Good afternoon, everyone, and thank you for joining this webinar. Yep.
Yeah, good afternoon. Myself, Shiva Ganeshan. I'm assistant professor from India. So I'm working as an as well as implant audiologist. And thank you, Sarah, and thank you, the team, for giving me the opportunity to join here. Thank you.
Good afternoon, everybody. My name is Manasseh Bocha from the Ministry of Health. Nancy, continue.
Yes. Mr. Manasseh, you can introduce yourself.
I have said my name is Manasseh Bocha from the Ministry of Health. Over to you.
Tangugi,
Assistant
introduce
Professor
yourself.
Ziva, welcome.
We do what we call an ear mold. We do an ear mold that is then affixed to the actual hearing aid. Bottom line is that hearing aids will enable one to be able to hear, and for children, help them to develop a speech and language. Thank you. Oh, one other thing, we also have what you call FM systems. FM systems just help, especially children in classroom settings, to be able to hear speech more clearly. They're able to hear their teacher more clearly in the midst of noise. You know, classrooms can be very noisy environments. So with an FM system used alongside with a hearing aid, then the signal, which is the teacher's voice, is able to be more audible for the child. And then, of course, then the child is able to learn better. Thank you. Over to you, Nancy.
Thank you so much, Ms. Sarah. With that in mind, we'll go to Assistant Professor Ziva. Why is it important to have early intervention for hearing loss in children with regards to what Sarah has presented about hearing aids?
Thank you, Nancy. And yes, just before going to this yearly intervention, let me just show you some prevalences for hearing loss across globe. You can see that specifically in Africa, it is like 39.9 million, as like this much of people have hearing loss. So those people are having moderate to higher grade of hearing loss. So when it comes to this much of people who have a hearing loss, we need to understand that different and in specific management as well as assessment options. So your question is about early intervention. So in early intervention, why we need to pressurize on the early intervention? What will happen if I intervened little bit later, not in the early stage? So there are we know that certain cases, like if you have a hearing loss, it is going to affect the communication. It is not only the case, it is going to affect the communication. There are numerous of studies says that if you have a continuous hearing loss, it is also going to affect our cognitive ability. You can see that unaddressed or the late intervention of hearing loss can cause to dementia in the older case as well as in the child. So it is going to affect the cognitive ability. So first thing we need to talk about early intervention to preserve and to develop our cognitive skills. The second thing is, so we have uh, statistics from the Norway says that people who have a hearing loss has a higher amount of possibility to drop out from the higher education. So it is again going to, like if we treat the patient, if we didn't treat in the early time, it is also going to affect the education status. Then another case, you can see that it is also going to affect the employment. So what I want to like pressurize, we know that the late implant or the early intervention. So we already know that these are all the some other factors is going to be contributing to the early intervention. The main thing I want to say you that you can see that unaddressed hearing loss or the late intervention of hearing loss can cost 980 billion annually, $980 billion annually. So this is a economical thing what we need to really look into our address. So not only this, as we all are in the medical field, we know about our brain. The brain has a pliable or plasticity up to certain age. For example, in a pediatric population, we need to treat the child within 5 years of age. Why this 5 years of age? This 5 years of age is known as a critical period or sensitivity period. So where you have a brain which is has a neurons, it is a pliable, it can able to learn everything quicker and better in this 5 years of age. So if we give any treatment or intervention within this 0 to 5, it is going to be rapid and exponential in the development. So if we go after 5 years, it is not that they're not going to develop, they will develop, but there will be a delay in the development. Thank you, Nancy. I hope I have answered your question.
Thank you so much. I'll go back to Sarah. Are there any, what is the importance of hearing habilitation, and what is the difference between hearing habilitation and rehabilitation?
So it's about rehabilitation. First of all, I just wanted to mention something about hearing loss being a hidden disability. That is very, very important. So one of the reasons that sometimes nothing is done early enough is just because of that. Just by looking at somebody, you cannot tell whether or not they are hearing or not. Back to your question about rehabilitation and rehabilitation, habilitation and rehabilitation. This is after some intervention has been instituted. Let's say you have given hearing aids, or for those children who have severe to profound hearing loss, you have given cochlear implants. So, for example, if I take a child who has severe to profound hearing loss and has just been given a cochlear implant, that becomes when they do switch on, that becomes their day one of hearing, the very first day they begin to hear. And so there is the auditory hierarchy where they go through, where you have to listen, first of all, sound awareness, and then being able to distinguish different words. This is a process. As you know, when a child is born, a child who is hearing begins to speak the first words probably towards the age of, around 9 months. There they say dada, mama, and all. Although they were babbling at around 6 months, but their first spoken words are towards 1 year. So they had a long and extensive period of listening and then learning how to speak. So rehabilitation is all about that. Just allowing the child to hear different types of sounds, to learn that aspect of listening, and then now producing the sound. So it becomes very important when, alongside with the intervention, the technology, which is now either the hearing aid, depending or the cochlear implant, that this child is learns how to do the same, listen and have the spoken, develop spoken, are coming so much like our later. So those kind of children, they want to look at your lips, they want to look at gestures. They have not developed that skill of being able to listen for sound and then be able to reproduce it through speech. Therefore, it means that rehabilitation is the most important component of the whole rehabilitation process after intervention has been done. And even as Professor Siva said, and I'll ask him to also jump in on this one, it becomes more expensive if you start rehabilitation much later. But if you do intervention early enough and then begin the rehabilitation process, that child is more likely to follow the natural curve of hearing. You know, like for example, in the West, where implantation is being done below the age of 1 year, that child will require much less going for speech therapy and that kind of rehabilitation. They will more likely just follow the natural, the natural curve of hearing and developing spoken language as a normal hearing child, as opposed to the same child getting implanted at age 5 and so forth. Thank you.
So, Professor Ziva, what is the candidacy of the cochlear implant? Can an adult do, what is the criteria for children and adults in terms of cochlear implant? Who is eligible?
Okay. So thank you, Nancy. Before starting with that, Sarah told about the important thing about the cost. And we think that when we are going for the yearly implant, or for example, when you are choosing a child for the implant at the age of 2 years or 1 year, most of the parent and most of clinicians are giving the excuse that we have 2 more years, we can do it later, or we can do it after 5 years. What is the problem? Like Sarah already told about the cost and everything. I also told you that from the WHO report, hearing report, you can see that if we treat the child within 4 or 5 years of age, the amount of speech therapy or amount of auditory verbal therapy we need to give for the child is comparatively less when we are treating the child after 6 years. So why it is like that, as she said, so when the child is typically developing, so it has all the environment in the within the 4 or 5 years. It has the ability as well as from the brain, like the neuron level. So it can learn everything in a quicker way. So if we give the AVT or speech therapy after 6 years of age, so what happens is we need to give, instead of 1 year therapy, we need to go for 1.5 or 2 years to go with the normal development. So it is a very good point that we need to keep in our mind that our like the candidacy when we are selecting, even though it's a child in the 1 year or 2 year, we need to understand it is going to increase their development compared to the light implant. So now I will come to your question, the candidacy of cochlear implant. So to understand before cochlear implant, I will just play a video. One second, sir. Nancy, can you able to see the screen?
Yes, we can.
Yes. I'll just play this video. I will give you the introduction about the cochlear implant as well. So we have a cochlear implant. Cochlear implant is a device. It's a bioelectronic device. It is going to replace our sensory organ, which is known as a inner asset. This is a sensory organ which is going to help us to convert acoustic signal into electrical. Unfortunately, in the hearing loss, in the hearing impairment clients, these hassles are not going to work as normally. What we need to do is we need to replace with some electronic device. We have a electrodes, which is known, you can see in the video clearly. So it has a 2 components. One is going to be outside of the skin and another going to be implanted inside. you can see an electrode which is enter into the cochlea, and you can see some tiny dots. These are the electrodes. These are going to give some electrical stimulation to the cochlea, and it will directly deliver at the level of auditory nerve. So when we are giving this auditory nerve direct electrical stimulation, it is going to give the hearing sensation to the clients. So you can see that how the auditory nerve is conducting all the electrical nerve. So you can see this is the normal cochlea process where your inner cell do the function. But when it comes to the cochlear implant, we don't. You can see the greener portion. These are the sensory, the 3 rows of cylindrical shape. These are the hair cells. So these hair cells, you can see that how it is it was green. Now it is after damage, it's shown as a gray. So once it is damaged, we need to replace these hair cells with a cochlear implant. You can see that now it is replaced with the cochlear implant. Once it is replaced with the cochlear implant, you can see how it is the yellow color highlighting is a current stimulus. So that's how we deliver from the acoustic sound, and we convert into with a speech processor, and then we deliver into the electrode. Then the patient can hear the sound as a. That's how a cochlear implant works. So we need to understand this thing before going to the cochlear implant candidacy. So if you understood this, now I will just pause this video and I will say you about the candidacy. So what we need to understand about candidacy? Who will be the candidate for the cochlear implant? A person who have a impairment or damage in the inner cell. So if you ask me that any person who have a cochlear, like inner cell loss can go to cochlear implant, no, there is a severity. For example, if it is mild or moderately severe or severe level, that means like up to 70 or 90 dB level, they can be benefited with the traditional hearing aids. So if any person who have a hearing loss beyond 90 dB, mainly profound hearing loss, they are the candidate for the, it should be bilateral profound hearing loss. But recently after 2019, FDA approved for the single side deafness. MEDAL got the approval for the single side deafness. Even we can go for the cochlear implant for the single side deafness. That means like even unilaterally you have the profound hearing loss, we can go with the cochlear implant. This is the first candidacy based on the severity. And second, so you understood that hearing aids are going to benefit, even though if it is a profound hearing loss, at least 3 months of time, I need to give a hearing aid trial for the cochlear implant patients before going to the cochlear implant. After 3 months of trial, I need to make sure that hearing aid didn't give any benefit. So the second candidacy is limited benefit from the hearing aid. Whoever has the limited benefit from the hearing aids can also chosen for the cochlear implant. The third one, we have something called speech performance. You have given, for example, you have a patient is severe to profound hearing loss. You have given bilateral hearing aid, but after hearing aid, the thresholds are okay, but the speech performance still shows a poor scores. So if after hearing aid still the speech performance is poor, then they are also candidate for the cochlear implant. So now, what is the age, minimum age to go for? Minimum you can start from 1 year of age. There is no fear to go start from the 1 year of age. It is not even we can start your bone conduction implant where you need the skull maturation. This kind of implants even start from 1 year of age. So cochlear implant is very safe to go from 1 year of age. So this is another age related criteria. And what other things we need to have? We should have the normal auditory nerve to go for the cochlear implant. If a patient who have a cochlear anomalies or cochlear nerve anomalies, need to go some modification in the cochlear implant. For example, if there is no auditory nerve, then they cannot be fitted with the cochlear implant. They should go with the auditory brainstem implant, which is somewhere in the brainstem level. So if they have these criteria, then they can be easily fitted with the cochlear implant. And before going to the cochlear implant, we should make sure that they are getting a less benefit from the hearing aid. If they get the benefit from the hearing aid, then we should not provide them with the cochlear implant. And another thing we should keep that in mind, cochlear implant is not a single day procedure. It is going to be a long-term procedure where you need to give 1 to 1.5 years of rehabilitation post-operatively. Nancy, I hope I've cleared you about the candidacy. Yeah.
Thank you so much.
Yes, sorry, Nancy. I just given you in more specifically for adult. I will also give you this thing. So in adult, again the same like hearing aids should have the less benefit, as well as you can go for the single side deafness. Like single side deafness, till now we are giving the cross hearing aids for the single side deafness. That means like if right ear has a profound hearing loss, we will fit the microphone like hearing aid in the left ear, and we will fit the microphone in the right ear. We will collect all the signal from right ear and we will deliver it into the left ear. But nowadays for adult, or after 2019, we got the approval. What we can do is we can collect the signal from right ear. We can deliver the signal same in the right ear. So what happens is we are just giving the binaural benefits to the clients in terms of single side deafness. So in adults, again, there is no age limitations. Even in the 60 years or 70 years or 80 years, even you can go do it. So only thing is we need to have the preoperative assessments. If everything is good, and as I said, that radiological report, audiological report, everything we need to correlate. If everything says the candidates, even if they are 90-year old, we can fit with the cochlear plan. They're going to benefit, and they need like they don't need to go for rehabilitation like a pediatric population. They can just go 2 or 3 months to understand the sound difference. After that, they can use as usual. So why we need to give the cochlear plan even the 90 years? I have already quoted the study. If you didn't treat the hearing loss even in the geriatric population, it is going to lead to the dementia. The recent studies are focusing on the cognitive decline in the geriatric population because of non-treating hearing losses. Thank you, Nancy.
Thank you so much. That was so informative. I have another question for, I think, Sarah. Sarah, this one might be for you. Is there a difference between programmable hearing aids and non-programmable hearing aids?
Yes, there is. But the main difference is especially when it comes to speech clarity, speech understanding. Some of the complaints that patients have is that, I can't hear very well in a very noisy background. Speech is not very clear. So the thing is that these ones are able to give you much better speech clarity, much better standing, the noise management. And now, of course, with the latest technologies that we have, you know that there is, with the Bluetooth connectivity, you can be able to stream your phone calls, stream music, through the hearing aids. So with the higher and better technology, you're also able to get much more from the hearing aid. And also, just to go back again to what I had mentioned earlier, in terms of even the comfort, listening comfort with the hearing aids, it is much better with the different technology that we have. Thank you.
Thank you so much. Mr. Manasseh, with you in the government and contact person in ear and hearing care, what is the government doing to help those who are hard of hearing, and also those to take care of our ears?
Thank you very much, Nancy. The ministry, together with the stakeholders, have developed a strategic plan 2023-2028 with clear objectives targeting those with hard of hearing. Prior to that, there was another strategic plan 2016-2021, which again in our region in Africa, I think we were the only country in the region that has managed to develop such a strategic plan. And it was actually highlighted in the World Health Assembly resolutions of 2017 as a best study for ear and hearing care in countries in our region. The strategic plan, which was developed by the ministry, was launched last year during the World Hearing Day on the 3rd of March. And it has 6 objectives. The first one is it aims to improve access and coverage for ear and hearing care services in line with the delivery of UHC. With this, we intend to establish at least one ear and hearing center or clinic, one in every sub-county. In the country, we have about 292 sub-counties, and we intend to do that. We intend to train, to have a sensitization package for health workers, targeting doctors, medical officers, nurses, midwives, on how to identify ear and hearing cases early and ensure that they are referred to the specialists as early as possible and as appropriately as possible. We also intend to establish maternal screening centers in every maternity unit in the country, so that, like what we have heard from Sarah and Professor, that it is good to pick these cases early. In fact, for rehabilitation regarding cochlear implant, it is desirable that they are rehabilitated before the 3rd birthday. So just like the way we have routine services in the MCH, would like to have the ear and hearing screening centers in every maternity in the country, so that once a child is born, they are screened. As we have heard from Sarah, we have today advanced technological techniques like ABR and BERA, which we can use to identify these cases early and rehabilitate or habilitate early enough. We would wish to also establish to train community health promoters on how to identify these cases of hard hearing early enough so that they can refer. So in the strategy, again, we have a robust monitoring and evaluation plan, so that as it is now, we don't have key indicators, we don't have key statistics to say what is the prevalence of hearing in the country. So through that robust monitoring and evaluation framework, we'd like to establish statistics which we can even help us to do research so that we can serve our clients better. Thank you.
Thank you so much. Maybe I would still add you another question. With the government rolling out the social health insurance fund, are there any possibilities of having items in ear and hearing care being covered by SHIF?
Thank you very much, Nancy. Last year, again, the ministry revised its Kenya Essential Medicines and Supplies list. And previously, the ear and hearing care commodities were not included in the Kenya Essential Supplies list, the one which facilities and counties propose from KEMSA. But we managed to include ear and hearing care commodities in our essential supplies list, because the NHIF and SHIF, they usually rely on these documents to empanel or to cover these commodities under their cover. So we, again, in SHIF, I have participated in the SHIF dissemination. The ear and hearing care commodities have been covered, like, for example, the provision of hearing aids. Hearing aids are covered under SHIF. Even screening is covered under SHIF. What has not been covered adequately under SHIF is the cochlear implants. But we are working with the team so that we have the cochlear implants covered under SHIF, just like the way they were covered under the super cover under NHIF. Thank you very much.
Thank you very much. Sarah, I would like to ask you a question about myths. Have you had any myths and misconception as regards to hearing loss intervention that you would like also to debunk? Sarah? Hello?
Sorry, I missed the question. Sorry.
It's okay. We're asking about, have you come across any myths, misunderstanding, or misconceptions about hearing loss interventions, and what are you trying to do to debunk them?
Thank you, Nancy, for that question. Yes, one of the commonest shall I say, myths or misunderstanding comes in regards to children who have delayed speech and language. And with that, there is always the possibility that that child with delayed speech and language has a hearing loss. But you'll find that even though sometimes some parents who are among the first people to realize that in a child, this child is not responding to sound, the myth around is that, people around them will say, no, you're just being overly cautious, you're being overly concerned, just give the child time, and with time, they're going to be able to, just develop speech and language. And you'd find that maybe they'll give you an example, your family members or friends will give you an example of another child, that one delayed in speech, and eventually they developed speech. And as a result of that, you find that this child is then given the first diagnosis at the age of 4 years, by which time, even as the discussions we've had, it's really towards the late stage because of all the things that we have discussed about neuroplasticity and how it also affects now even schooling, because if at all, for example, a child had a severe hearing loss and was implanted at the age of 5, it means that they are beginning to learn to listen and to learn their first words when they're supposed to be in PP1. By that time, the other kids are, 5 years ahead of this child hearing-wise. So you find that that child will go through the school system struggling a lot. Whereas if that child had that diagnosis because the child was not developing speech and language well and was referred for a hearing check, if it had been picked much earlier, then that child would have had the chance of 2-3 years before they even enter into school to have rehabilitation and learn to listen and speak. So that's one of the things. And I think one of the reasons being because hearing loss generally is a hidden disability. And just to look at somebody, you can't tell that they necessarily don't hear. It could even be a moderate hearing loss, which will affect the child's, the process of learning how to speak. So one thing is that if a child has got delayed speech and language, they must have a hearing assessment done. So at least you rule out that. Secondly, if it's a child who has had one of the risk factors for hearing loss, for example, meningitis or severe jaundice, all those risk factors associated, especially for newborns, there is the newborn hearing screening that is for all the children, but also you can have targeted based on the risk factors, children who are born preterm, children who are below the age of 1,500 grams, or those who have had been in NICU, neonatal ICU for more than 5 days. Those ones must have a hearing assessment done. Whereas we are saying all children should be assessed, but especially those ones where the programs are not in place. And we know in our country, it is yet to happen. And as Mr. Manasseh from the ministry said, we have already put it in the strategic plan. And so the ministry is working together with partners to make sure that those programs are begun in the hospitals. The other thing is, the other one is about the issue of cost. We say intervention is very expensive, but even as has been discussed here, it is more expensive not to intervene in good time. If you wait, then there is much more money that you're going to put on long term. So whereas it may look like initially it is a huge expense, but in the long term, if you're looking at it long term, and even WHO has already just put out there what the investment that is when you put in early, in the long run, it is much, much cost effective to be able to intervene early as opposed to waiting until later. And we are happy that the Ministry of Health is also has included hearing aids in the Kenya Essential Supplies list, so that now the government will begin to budget for that. But before the programs and everything has been rolled out, it is important to encourage the patients that we see that if a child has a hearing loss, they make all efforts to see that intervention is made. Thank you. Over to you, Nancy.
Thank you very much, Sarah. Manasseh, I would also want to ask you one more question. As concerns the strategic plan and the guidelines, are they available in the MOH portal for people who want to get a glimpse of it? Is it available?
Yeah, thank you, Nancy. The strategic plan is already in the Ministry of Health portal, www.health.go.ke. If you log in, you can find it. We are in the process of also uploading the guidelines. And again, we have started a series of dissemination because putting it into public domain is one thing, but understanding, making our audience understanding is another thing. So we have started a series of dissemination. Already we have done one dissemination to the national health facilities and institutions. We have sensitized the Kenyatta National Hospital, NTRH, Kenyatta University Hospital, Spinal Injury, Mathare, and KMTC. And in each of these institutions, we have picked we have identified what we call champions or focal persons, so that now they'll be working with us towards taking this work of ear and hearing care way forward. The next move is to reach to all the counties. We have grouped the counties into regions, about 7 regions also. So we are working together with our partners so that we start regional sensitization, where all the counties will be reached with the dissemination information, so that we move together in the same direction. And in each and every county would like to identify champions or focal persons who will now ensure that the activities as per the strategic plan and also having the guidelines cascade to all the health facilities in their jurisdiction. So that is something that it is in our plan to do immediately this year. Thank you.
Thank you very much. I'm just receiving other questions on the chat, on the question and answer section, and I will have it open. A child who has had meningitis during his course of life, what does it do to hearing, and what can be made to restore hearing to this child? Maybe I'll throw it maybe first to Sarah.
Thank you. This is a very important question. This is a child, I believe, who was probably post-lingually deaf. That means they have developed the meningitis after having developed speech. Although it could even happen before, it doesn't matter. But meningitis is actually an emergency so far as cochlear implantation is concerned. That means that if the meningitis leads to profound deafness, then what normally happens is that within the cochlea, that's the inner ear, it begins to harden inside. We call that calcification. And so because it begins to harden very, very quickly, it is not possible. It gets to a place where it is completely ossified, that you're not able to insert the cochlear implant. And that is why it is an emergency. So what are we saying? We're saying post-meningitis, after a child is treated for meningitis, the next very important thing they must undergo is a hearing test. And should we find that the child has got profound deafness, then very quickly that cochlear implantation needs to be done. Thank you.
Maybe Dr. Ngugi, what are some of other complications of meningitis have you encountered, maybe either pre or post or in surgery, as regards to ear and hearing care?
There are things that happen sometimes associated with meningitis, is that sometimes you can have occult ear infections that now make your surgery difficult, or make your surgery you have to abandon or postpone your surgery. So, for example, if this child got meningitis and had a ear infection that preceded the meningitis, you'd find that you'd have to deal also with that ear infection during that point. Sometimes you also get a very what we call sometimes a fixed foot plate because of recurrent ear infections with some of these patients who we have had recurrent meningitis. Post-op, most times there isn't much. They are not any different from any other patients post-cochlear implantation, or post even when you have to do other ossicular chain reconstructions or anything that you need to do for them, then it's nothing much special, but just know that sometimes meningitis affects other parts of the brain, and that child is left in has a less cognitive state, poorer cognitive state than before they had meningitis. So, for example, a 10-year-old who now behaves like a 4-year-old or a 2-year-old. So you literally start retraining them. Even if they can hear, you're actually now trying to retrain them on what they were hearing before, how to sit, how to walk, how to verbalize, how to sign, and so on.
Does it also apply to adults?
For adults, it's a lot less, cognitive impairment occurs a lot less in adults as their brains are a bit more robust. But when it does happen for them, it tends to be a bit more difficult to manage them. Whereas in children, their brains tend to be a bit more plastic. So they tend to also be able to, they also tend to be, children you find will be able to sort of like adapt and find new neural pathways for you to teach them either speech or sign.
Thank you very much, Daktari. I have another question from the question and answer section. Probably, Sarah, are there any myths around hearing loss and the weather, hearing loss and they've said hearing loss and weather?
So what normally happens, for example, the ear we know is divided into 3 parts. You have got the outer ear, the middle ear, and the inner ear. The middle ear is connected to the nose and throat through a tube that's called the eustachian tube. When the weather changes, you get a flu, a cold. That means then you may have the middle ear being affected. For some people, it is you might get because of eustachian tube dysfunction for a period of time. That may cause you to feel like, pain or like a blockage in the ear because you have now you develop what you call negative is sustained. Then especially for children, it can begin to collect fluid. We call that otitis media with effusion. And then, of course, now your hearing is impaired. But most oftentimes when you have a cold, when the weather changes, when that eustachian tube is not equalizing the pressure in the middle ear and, the atmospheric pressure, then you tend to get a feeling of blockage. And that's why I think the question was asked as to why is it that this person sometimes feels when it's cold weather, they hear a little bit worse. The same kind of thing can happen when there is a change of altitude. Let's say you are flying or, from one altitude to another, that when the eustachian tube shuts, you might feel like your ear is kind of like blocked, and some people even feel pain in the ear, or even like diving, or those are the kind of scenarios. Yeah. If you will allow, Nancy, there's a question on a child, what is the age bracket for implantation? And I'll ask Prof. Siva to respond.
Yes, go ahead.
Yes. So there is a question about, is there an age bracket for the implant, below which the implant will be of no help in speech learning? Yeah, there is as I said, that our priority is to give the implant within 6 years of age. But if we couldn't give within the 6 years of age, if you ask me, what will happen if I treat a patient in 7 year or 8 year old, definitely they will get the benefit, but there will be a limited benefit. But what will happen is, how we need to understand is, most of our speech and language development stops at the age of 7 years. So most of our language develops and finish at the age of 7 years. So after that, we start to acquire the higher linguistic skills. So if we start to implant after 7 years of age, so what happens is, we need to work with the child for extra period of time. For example, rather than 1 year of therapy, at 1.5 year of therapy, maybe we need to work 2 or 3 years of therapy. So if you give the continuous therapy, but after end of the time, the child is going to get the language, the child is going to speak, develop the expressive language, as well as the child is going to communicate, but it takes a bit longer time. So if we give the option whether it should be do it 6 years before or later, it's always good to go before 6 years of age. But if you missed within 6 years of age, if they come in 8 years of age, if you ask me whether should I need to treat or not, definitely you need to treat, but you need to tell them they need to go for the intensive auditory therapy as well as speech therapy. Thank you, Nancy.
Thank you so much, Professor. There's also a question about hearing loss in pregnancy. Can you is there a myth that is there something related to that?
Yes, it's a very good question. Not only related to pregnancy. So, like mostly in the pregnancy time, due to hormonal imbalance, like you can see some changes in the like metabolism. But the person who was asking about the hearing loss, mostly we have seen some clients after the pregnancy because of the medications or the drug what they have taken. So we will call it as ototoxicity. In ototoxicity, it will affect certain frequencies and it will also cause to a sudden hearing loss in the nature. But it is not very common. We have seen some rare cases of in the pregnancy. I don't know what situation in Kenya. The person asked how common is pregnancy related to hearing loss, heating in Kenya, and what are the causes. So mainly hormonal balance. In some cases, cause of ototoxicity because of the medication what they are taking. There are it varies to person to person.
Thank you very much. Thank you so much. There's also a question on how appropriate is the medication for ear infection during PASS? I think Dr. Ngugi can answer this one.
Can you repeat the question? I didn't catch that last part.
The appropriateness of medication, when appropriateness of, let me just read the way it's written. What is the appropriate medication for ear infection that produces PASS?
Okay. So ear infections that produce PASS usually can either be viral, bacterial, or fungal. So most common in our setup is viral. So most of the things we tend to give the patient is we give them analgesia to manage the fever, because most times the body itself will tend to self-limit these infections. Only when we notice that the fever persists beyond 24 to 48 hours, now we decide to institute oral antibiotics. Now, if the ear is producing PASS in an acute setting, that is, this is not something that commonly happens, the child is usually well, and this is not a disease that's been recurring for time, then there's usually no really indication for them to get eardrops, because usually what has happened is that you've had what sort of like a boil within the middle ear, and then this boil has ruptured, and the rupturing is the eardrum that has ruptured and has released this PASS. But if you have this as a chronically recurring thing, that every time this child gets a cold, there's discharge, the child has poor hearing, they're not getting very severe fevers, then, and this is something that has been occurring for more than 3 months, then we move into a chronic situation where now this patient needs to be put on high dose drops for the ears, which are high dose antibiotic drops with also sometimes also added a steroid on top. And once it clears, it means that this child will have to have this child or adult might have to have surgery to repair the eardrum, as the eardrum will not heal by itself.
Thank you very much, Daktari. Sarah, are there with patients who undergo chemotherapy and have been through the hospital, is there any dangers to hearing, and what can be done to prevent, or rather prevent them from getting hearing loss?
Okay. Thank you, Nancy, for that question. Yes, indeed. Sorry. Yes. Yeah. Thank you for that question. The commonest cancer medication or chemotherapeutic drug that causes hearing loss is called cisplatinum. So usually for cancer patients or patients receiving treatment for cancer would usually go for, especially if they are likely to use medication that is known to be ototoxic, that means that can cause hearing loss, then the first thing would be to have a baseline hearing test, and then that hearing is monitored over time just before they go for the next dose of treatment. That is important because then that if the hearing is being affected, it gives the doctor an opportunity to either change the treatment or whatever they need to do. They can make a decision. The most important thing, obviously, is to understand that the cancer is the more important or urgent thing that has to be managed. But we leave that to the discretion of the doctor as to whether, if at all, the medication that is being used is ototoxic, is causing hearing loss, then that is upon the discretion of the oncologist to decide whether they are going to change that drug or not. If by any chance, because of the nature of the treatment, they are not going to be able to change the drug that is causing ototoxicity, in this case, a chemotherapeutic medication, then at least you can be able to now look at the intervention options, which could be hearing aids, depending on the level of hearing loss, or a cochlear implant if the medication leads to profound deafness. Thank you.
Thank you very much. There is also a question about, someone is also asking about quinine and ototoxicity. I think you can continue with it.
That is correct. Again, quinine also is known to cause, is ototoxic. And when that happens, actually, most of the time it is severe to profound. But again, going back to the discretion of the doctor in terms of when they are using the quinine, and more often than not, quinine, especially IV, is used when the patient's condition is very severe. The malaria is very severe. So sometimes it is a gamble between the patient's survival and whether or not ototoxicity will be caused. So there are times when certain antimalarials will not, the patient does not respond to them, and then the option is left for quinine, in which case we cannot, the doctor is not left with any choice but to administer the quinine, although we know that potentially it is ototoxic. So one would imagine that depending again on the severity of the malaria, the doctor would decide which are the safer medications, that means more effective, but less likely to cause ototoxicity. They would use those ones. But if it is very severe, life-threatening for the patient, and quinine is the option, then I guess it has to just be given. But the truth is that quinine does cause hearing loss, and it can be severe to profound.
Thank you so much, Sarah. Maybe I would like to give Manasseh to tell us briefly on how this year's World Hearing Day was celebrated, and maybe mention key highlights.
Yes, thank you, Nancy. This year's World Hearing Day, usually the World Hearing Day celebrations are celebrated on the 3rd of March every year. But this year, the 3rd of March fell on a Sunday, so we purpose to celebrate the World Hearing Day celebrations on the 4th of March. All systems were ready to go, but we faced some unavoidable challenges on the 4th, so we pushed it forward to the 21st of March. So we had the celebrations at the Kenyatta International Convention Center, KICC, where we celebrated the World Hearing Day, and this year's theme is changing mindsets, and let's make ear and hearing care a reality for all, with a focus on tackling the challenges posed by societal misconceptions and the stigmatizing mindsets through enhanced awareness and information dissemination. That was the theme for this year. And for us to be able to do that, we had to invite a number of stakeholders, including academia, the deaf communities, the hard hearing community itself, the Minister of Education, the Minister of Health, NGOs that are responsible for the deaf, like Christian Blind Mission, the NFDK, the Kenya Society for Deaf Children, KISE was there, the Hearing Health Alliance, MEDEL was there. So in total, we had more than 70 stakeholders who came, and we sensitized them on the ear and hearing care strategic plan, the one developed in the ministry, and the guidelines. So that is what we did on the 21st of March. Those two key events, we celebrated the World Hearing Day. The chief guest was our Principal Secretary, Harry Kimutai of Principal Secretary Medical Services. He was the chief guest. And it was a good occasion. We had a number of booths for display. Most of the companies that deal with hearing aids, Turkey, Nairobi House of Hearing, and the like, MEDEL, they were all there, and it was a good and a successful occasion. Thank you, Nancy.
Thank you so much. I would give this opportunity to all the participants to have a parting short message as regards to ear and hearing care. I will start with Ngugi, Dr. Ngugi.
I just want to say, as for this year's hearing and ear care, I just want to say my take home is please don't put anything in your ear. If you're worried about them, come see an ENT specialist.
Thank you so much, Daktari. Ms. Sarah Ndegwa.
So my parting shot is just about early screening, early diagnosis, and early intervention. The JIG, what do you call it? International Joint Committee on Infant Hearing Screening proposes that screening should be done at 1 month, and then diagnosis at 3 months, and then intervention at 6 months. Recently, that has been brought down to 1, 2, 3. So by 3 months, intervention must be done. So we are insisting that it is important for any child to have a hearing screening as early as possible, preferably after birth. And if not, then even during the time for immunization clinic, the Well Baby Clinic. And if a child has any of the risk factors that we mentioned for hearing loss, refer them to an audiologist where they can have that assessment done. And remember, hearing is across the life course. I know we are concentrating a lot about children, but one can develop hearing at any time. We have from newborn, even as a young adult, if you're exposed to loud noise, you can develop hearing loss. And of course, there is the hearing loss that is associated with getting older, what we call presbycusis. And you have been taught today about the impact of that on a person. So this is available in the country. It may not be available, at least in the hospitals that are near to you, but it is available in the country, both the diagnosis, like someone has asked a question, is it possible to have early intervention and diagnosis at the primary level of health? Yes, it is possible to the extent that two things, that we have the personnel, the human resource, and that we have the infrastructure. It is very possible to do that. And the government is looking towards this, as Manasseh has alluded to, especially the screening in the lower level, level 1 and 2. Screening can be done, and then diagnosis can be done at probably level 3 and intervention 4, 5, and 6. Now, to that end, I would like to inform our viewers today that our audience today that the University of Nairobi is in the process of establishing and beginning a new degree program. It's an undergraduate program in audiology and speech and language pathology. So be on the lookout for that. We are planning to do that by this year, the first intake. So for those who would be interested, you can reach out to us. Because I think for those who are living straight from school, it will not be in the COOPS, because the COOPS has already done their selections and so forth. but that is what is ongoing. And then we have the KMTC also have a program for hearing therapy and speech. So this is one of the ways that we can be able to cascade these services all down if we develop our human resource. Thank you very much.
Thank you very much, Ms. Sarah. Assistant Professor Ziva, parting shot?
Yeah. For this today's occasion, I would like to share some take-home message. Like as Sarah said, the yearly intervention will be my first take-home message for you. It's like you understood that why we need to do the yearly intervention. The second thing which I want to emphasize is counseling. Doing a proper counseling and giving all the options in front of patient to select whatever necessary management where they need to go. So by giving them the advice about the yearly like critical period, brain plasticity, and the cost of doing the late implant or late intervention, by doing the proper counseling and having a proper team work with the other fellow professionals, I think we can mitigate all the issues in the hearing loss and hearing loss intervention. I would like to finish with this. Thank you, Nancy.
Thank you very much. Mr. Manasseh?
Yeah, thank you, Nancy. Today, about 1.5 billion people globally have some degree of hearing loss. And this is estimated to rise to 2.5 billion people globally by 2050. In fact, by 2050, it is estimated that at least 1 out of 4 people will have some degree of hearing loss because of today's habits. Always plugging in our ears with phones, with earphones, ear plugs, and too much noise in our matatu industry. Therefore, we need to focus on prevention and promotion. Today we have advanced technological advances. Nobody should suffer silent disability, which is we are calling hearing. Any case of hearing disability, whether young or old, kindly bring them to us, to hospital, so that they are identified early and rehabilitated early. I used to work in Lamu, and I used to be the only ENT specialist in that level. And we used to do laryngoplasties and tympanoplasties with the Lions Club of Nairobi, Dr. Dean of Aga Khan. They used to come there, and we worked very well, and we really assisted quite a number of people. Therefore, nobody should suffer. Bring them early so that they are rehabilitated early.
Thank you very much. This was a beautiful discussion. We hope that every viewer has gotten something out of this. I really appreciate all the speakers and appreciate them. Dr. Ngugi, Ms. Sarah, Assistant Professor Ziva, and Mr. Manasseh from the ministry. Thank you so much for your presentation and answering the question. Thank you so much, KNH and UN webinar forum and the people hosting this meeting. Thank you so much. And I forgot to introduce myself. I'm Nancy Kemunto. I'm an audiologist working at the Kenyatta National Hospital. Hopefully we will have another good discussion like this. And if you have any questions, you can also visit Kenyatta National Hospital at the ENT clinic, Clinic 34, so that you will get more questions answered, or if you want to be screened or have a test done, you'll have it done. Thank you so much and have a good afternoon.
Thank you, Nancy.
Thank you, Nancy, and
everybody.
Okay, bye-bye.